today we're going to be talking about echo in pregnancy and in peripartum complications. In terms of our objectives, we're going to review the changes in maternal hemodynamics during a normal pregnancy and the associated findings that we see on echo during that time period. We're also going to discuss high-risk cardiac conditions in pregnant patients, and more specifically, we're going to discuss echo findings in patients with pre-eclampsia, amniotic fluid embolism, as well as peripartum cardiomyopathy. So pregnancy in itself is associated with significant hemodynamic changes, and this causes it to be a potentially high-risk period, especially in women with underlying cardiovascular disease. One of the key changes that we see in pregnancy is the increase in the blood volume. And this in itself increases the preload, and as a result, the maternal cardiac output increases by 30% to 50% during pregnancy. In addition to the increase in the preload, the heart rate also does increase in pregnancy, which contributes to a small increase in cardiac output. Finally, the systemic vascular resistance decreases in pregnancy, which is related to increased levels of estrogen and progesterone, and this leads to lower mean arterial blood pressures as well. These hemodynamic changes were studied previously in order to provide a reference range in general, although there hasn't been well-established thresholds in literature. This here is an example of a study that was done back in 2018, where the investigators enrolled 600 pregnant women. And the authors here used Dopplers to calculate VTI of the flow across the LVUT in these patients. And what they found was that there was a general trend for the stroke volume and the cardiac output to start rising at the 10th week of gestation. On the other hand, the systemic vascular resistance started to decrease at 10 weeks of gestational age, and it started to increase again around term. It's important to note that the cardiac output and not cardiac index should be used to accurately assess maternal hemodynamics in pregnancy. And this is because there is a substantial amount of weight gain during pregnancy. So the body surface area has also changed. And it's thought that the rise in the body surface area is mostly due to the increase in the blood volume as opposed to the formation of a true metabolic mass. As a result, the cardiac output and the stroke volume increase in pregnancy, but the indexed values may not change. As we mentioned before, pregnancy is associated with significant hemodynamic changes, and this can exacerbate pre-existing cardiac disease during pregnancy or in the postpartum period. The Modified World Health Organization classification of maternal cardiovascular risk is used to estimate morbidity and mortality in pregnant women with cardiovascular disease. So in women who fall under class 1 category, the cardiovascular risk is very low, whereas women who fall under class 4, these patients should be advised against pregnancy due to an extreme high risk of maternal mortality. This here shows more details on the cardiac conditions that fall under each class. So for example, class 1 consists of low-risk lesions that are not associated with a significant risk of morbidity or mortality during pregnancy. These conditions include mitral valve prolapse, repaired ASDs and VSDs. And in general, cardiology follow-up during pregnancy in these cases may be limited to 1 or 2 visits. On the other hand, the mortality and morbidity risk associated with pregnancy gradually increase with each class, and it reaches an extremely high risk in the 4th category. This includes patients with pulmonary hypertension, severe mitral stenosis, as well as severe LV dysfunction. Patients with severe aortopathies also fall under the class 4 category and should be advised against pregnancy. In terms of the indications for maternal echocardiography, very few guidelines detail the indications for screening echoes in pregnancy. The American College of Obstetrics and Gynecology recommends that a TTE should be performed in all pregnant women with a known history of structural or congenital heart disease, and in patients with a known history of exposure to cardiotoxic chemotherapeutic agents. However, there is insufficient information or guidelines on the role of echo in pregnant women without known structural heart disease. And this leads to our major topic, which is the structural and the echocardiographic changes that we expect to see during a normal pregnancy. This here is a study that was published in Circulation back in 2012, which included 51 pregnant women, and the investigators here did serial echoes in each trimester and again in the postpartum period. What they found was that the systolic, diastolic, and mean arterial blood pressures did decrease, reaching a nadir in the second trimester, followed by a slight increase towards the third trimester. And what they also noted was that the total vascular resistance decreased during pregnancy, reaching a nadir in the second trimester. And as we mentioned before, the cardiac output progressively increased during pregnancy, reaching a maximum in the third trimester. In terms of the morphologic changes, the investigators noted a significant increase in the left atrial size in the third trimester compared to the first one. There was also a significant increase to the LV mass by the third trimester. The authors also noted that there was a significant increase to the end diastolic diameter as well as to the end systolic diameter by the third trimester. So there is a degree of LV dilation that we see in pregnancy, and that increase in size is statistically significant, but it's important to note that the chamber size did stay within the upper range of normal. What they also noted is that the sphericity index did decrease during pregnancy, which indicates a more spherical shape of the LV towards the third trimester. All of these morphological and structural changes did normalize again in the postpartum period. On the other hand, in contrast to the structural changes that we see in pregnancy, there were no significant changes to the LV function. In terms of diastolic changes in pregnancy, there are multiple studies that suggest that we can see changes to certain diastolic parameters in late pregnancy. This here is another example of a study where 37 healthy pregnant women did have serial echoes during each trimester, and again in the postpartum period. There was a significant increase in the E-value in the first trimester. And this again is thought to be related to the increase in the passive LV filling that we see in the first trimester. However, by the onset of the second trimester, there was a gradual increase in the A value. So there was a decline to the E to A ratio in late pregnancy. This is thought to be related to the state of volume overload that we see in pregnancy. So the LV-EDP increases and it peaks during the second trimester. And as a result, a stronger atrial contraction is needed to complete LV filling. Another possible explanation to this gradual decrease to the E to A ratio is that the increase to the LV thickness during pregnancy may reduce ventricular compliance, and this requires a more powerful atrial contraction to complete LV filling. Similar findings were also reported in a cross-sectional study that enrolled 560 pregnant women. And what they found was that a significantly higher proportion of pregnant women in the third trimester and at term, estimated at 13% and 18%, did develop a mild degree of diastolic dysfunction compared to the non-pregnant control. There was also an evidence of segmental myocardial diastolic dysfunction, which was seen in 28% of pregnant women at term. And what they also noted is that at 1 year postpartum, there was full recovery in the diastolic function on repeat echo. There's a large body of evidence that discusses the morphological and functional changes that happen to the LV in pregnancy, and there's only a limited number of studies that investigate the changes that we may see to the RV during that time. The cardiac hemodynamic imaging and remodeling in pregnancy is a study that enrolled 34 pregnant women where they had both an echo and an MRI in the third trimester and again 3 months postpartum. What they found was that the RV end diastolic diameter increased significantly in the third trimester. There was also a significant increase in the RV mass as determined by both echo and MRI, and there were no significant changes to the RV systolic function as measured by echo or MRI as well. In terms of valvular changes, pregnancy can lead to progressive dilatation of the annulus, which is mostly mediated by the physiologic volume overload. This study here investigated the extent of annular dilatation throughout pregnancy. And essentially, they noted a gradual and significant enlargement of the tricuspid, mitral, and pulmonary annular diameters. On the other hand, it was noted that the aortic annular diameter did not vary significantly throughout pregnancy. And when they looked at the valve function, there was a progressive increase of physiologic regurgitation affecting the mitral, tricuspid, and pulmonary valves. However, there was no evidence of the development of any aortic regurgitation during any of the stages of pregnancy. One of the other cardiac changes that we see in pregnancy is the development of a pericardial effusion. This study here enrolled 52 healthy pregnant women where they had an echo in each trimester, and essentially there was a pericardial effusion seen in 15% of women in their first trimester, and this increased to 44% by the third trimester. The etiology to this pericardial effusion is again related to the development of a physiologic volume overload state that we see in pregnancy. And this pericardial effusion was found to be completely resolved in all women who underwent another echo 6 weeks postpartum. Next, we're going to talk about echo findings in pregnant patients with heart disease, and we're going to discuss a few cases. The first case here is a 37-year-old woman who presents with exertional dyspnea at 25 weeks of gestational age. Her past obstetric history was significant for a previous miscarriage at 3 months of gestation. She was found to be in atrial fibrillation and was clinically volume overloaded. And she was also noted to have a 3 out of 6 diastolic rumble that was heard best at the apex. This is the parasternal long axis view showing typical features of rheumatic involvement of the mitral valve with severe mitral stenosis. Her left atrium is also severely dilated, and on color Doppler, there's turbulent flow across the mitral valve there's also a trivial mitral regurgitation. This here shows the CW Doppler assessment of the mitral valve. The mean pressure gradient across the mitral valve is severely elevated, and her pulmonary artery systolic pressure was estimated at 53. At this time, she was on high doses of metoprolol, and she was started on IV diuresis. And after joint discussions with cardiology, anesthesia, and obstetrics, she underwent a percutaneous balloon mitral valvuloplasty. She gets her repeat echo after her procedure. The pressure gradient across the mitral valve did come down to 9, and her pulmonary artery systolic pressure is now 32. She continued to improve, and she was able to return home for the remainder of her pregnancy and eventually had a normal delivery. And at 2 months postpartum, her echo shows even further improvement in the mitral valve hemodynamics and in the left atrial volumes as well. So the take-home point from this case is that mitral stenosis in women of childbearing age is mostly due to a rheumatic etiology. asymptomatic pregnant patients with mild MS usually have favorable outcomes, but most patients with moderate to severe MS present with increasing symptoms during the second trimester because of the significant increase in the plasma volume, and this can be associated with significant morbidity and mortality. In the Registry of Pregnancy and Cardiac Disease, which is a European database, they found that 49% of pregnant women with severe MS and 32% of pregnant women with moderate MS were hospitalized during pregnancy or in the postpartum period with decompensated heart failure. In a statement that was recently released by Jack, percutaneous balloon mitral valvuloplasty is now the treatment of choice when mitral valve repair is indicated during pregnancy. There are no specific guidelines for the timing of the valvuloplasty during pregnancy, but it's recommended to go ahead with the procedure after 20 weeks of gestation, just to reduce the risk of radiation injury to the fetus. They also noted that in order to avoid the risk of extreme prematurity in the case of the need for an urgent delivery due to any procedural complications, that the procedure should be performed ideally during 26 to 30 weeks of pregnancy if possible. Next, we're going to talk about AS in pregnancy. In women of childbearing age, AS is most commonly due to a congenital bicuspid aortic valve, which may or may not be associated with aortopathies. And in general, adverse maternal and fetal outcomes increase with the severity of AS. According to the European guidelines, pregnancy is contraindicated in severe symptomatic AS or in patients with severe asymptomatic AS when associated with either an impaired LV function or with an abnormal exercise stress test. This here is a study which assessed the outcomes of pregnant patients with congenital AS who are actually followed here at TGH and Mount Sinai. And congenital AS in this study was defined as stenosis secondary to bicuspid aortic valves, subvalvular, or supravalvular lesions. What they found was that the peak aortic gradient did increase during pregnancy, but this increase did not reach statistical significance. However, when they repeated the echoes in the postpartum period, that increase in the peak gradient did normalize again. In terms of adverse events, there were no cardiac complications seen in women with mild to moderate AS. However, they noted a 10% rate of cardiac complications in pregnant women with severe AS. And these complications mostly included the development of pulmonary edema and recurrent atrial arrhythmias. In contrast to stenotic lesions, which are poorly tolerated in pregnancy, it has often been stated that regurgitant valve lesions are well tolerated because of the decrease in the afterload and the decrease in the systemic vascular resistance that we see in pregnancy. However, you can also argue that the increase in the plasma volume during pregnancy can lead to annular dilatation and can result in some worsening of the underlying regurgitation. And a study that was published in JACC 2 years ago tried to answer this question. And they aimed to assess the incidence of adverse cardiac events in pregnant women with chronic, moderate, or severe regurgitant valve lesions. And these adverse outcomes included heart failure, sustained arrhythmias, and cardiac death. And what they found was that pregnant women with underlying aortic regurgitation or pulmonic regurgitation were at the lowest risk of cardiac complications during pregnancy. However, there was a higher incidence of adverse cardiac events in patients with underlying mitral regurgitation or tricuspid regurgitation, as well as in patients with multivalve regurgitation. So the authors argue here that perhaps the lower systemic vascular resistance and the physiologic increase in the heart rate, which shortens diastole, may reduce the degree of aortic regurg or pulmonic regurg. In addition, the semilunar valve regurgitation may be less affected by the annular dilatation that occurs in pregnancy. When they did the subgroup analysis of women with MRTR and multivalve regurgitation, they noted that cardiac events were more likely to happen in women who have a high-risk feature. These high-risk features included a previous cardiac event, a history of LV dysfunction, as well as pulmonary hypertension. And that difference in outcome was statistically significant if the patient had one or more of these high-risk features. So this is really to say, yes, pregnancies in women with regurgitant valve lesions are generally considered low risk, but you also have to keep in mind that there are certain clinical variables that can help us identify those at the highest risk for developing complications. Our second case here is a 42-year-old woman in her 30th week of pregnancy. She previously had a mechanical mitral valve replacement. She has a history of irregular and subtherapeutic use of her low molecular weight heparin, and she presents with severe dyspnea. Her echo here shows a large thrombus causing an obstruction of the prosthetic mitral valve. The mitral valve area here is estimated at 0.6, and the mean diastolic gradient across the mitral valve is estimated at 29. This is her 3D transesophageal from the left atrial side, essentially showing the thrombus on the prosthetic mitral valve with a restricted movement of the septal leaflet. The patient in this case was given TPA, and her echo here shows complete lysis of the previously seen thrombus. Her mitral valve gradient is now decreased to 4, and the valve area has increased to 2.7. So women with mechanical heart valves have a high risk of adverse maternal and fetal outcomes. The gold standard for anticoagulation in the setting of mechanical valves is warfarin, and the risk of developing embryopathies secondary to warfarin during pregnancy is dose dependent and is usually the highest during the first trimester. As per the European guidelines and the American guidelines, if the mother is on less than 5 milligrams of warfarin, there is a class 2A recommendation to continue that dose in the first trimester. Otherwise, if the patient is on greater than 5 milligrams of warfarin, it's recommended to switch to either low molecular weight heparin or unfractionated heparin. Then in the second trimester, when there is no risk of developing embryopathies, the recommendation is to switch back again to warfarin. It's important to note that a large number of cases of valve thrombosis in pregnancy happen during transitioning between warfarin to low molecular weight heparin in the first trimester. And many of the thromboembolic complications are associated with subtherapeutic levels of anti-10A levels. So the guidelines recommend that we never just rely on weight in the dose adjustment of low molecular weight heparin in pregnancy, and that the anti-10A levels must be monitored very closely, and it should fall between 0.8 to 1.2 4 to 6 hours after the dose is given. This is our third case here. She's a 25-year-old patient at 32 weeks of gestation. She's presenting with a month history of progressive dyspnea. She has signs of RV overload on exam, including an elevated JVP, and she does have bilateral lower limb edema, and she does have a right parasternal heave. Her echo here shows severe RV dilatation hypertrophy, and her right atrium is also severely dilated. She does have severe tricuspid regurgitation with a max TR velocity of 5.6. She has no evidence of left to right shunt on her echo with contrast injection. Otherwise, her LV was normal. A VQ scan and ultrasound Dopplers excluded pulmonary embolic disease. She had a PA line in, and the numbers were in favor of primary pulmonary hypertension, and as a result, she underwent an urgent C-section and tubal ligation. So pulmonary hypertension is very poorly tolerated among pregnant patients. Different studies looked at maternal mortality in pregnant women with pulmonary hypertension, and it does range between 9% to 50%. In healthy pregnancy, you see a decrease in the pulmonary vascular resistance as the cardiac output increases. However, in pregnant women with pulmonary hypertension, the compliance is reduced and you can't really adapt to the increased pulmonary blood flow. In addition, pregnancy is a very prothrombotic state, and the combination of thromboembolism and pulmonary hypertension can be very detrimental. So essentially, the most common causes of death in pregnant patients with pulmonary hypertension include right-sided heart failure, pulmonary thrombosis, and pulmonary hypertensive crisis. There isn't really a safe cutoff in terms of pulmonary pressures before proceeding with pregnancy. And as per the World Health Organization, pulmonary hypertension falls under the 4th class category, and pregnancy is contraindicated. Our next case here is a 30-year-old woman at 32 weeks of gestation. She's presenting with acute onset of severe chest pain and dyspnea. She does have a known history of Marfan syndrome. She's clinically in heart failure, and her chest X-ray shows an enlarged cardiac silhouette with a widened mediastinum. Her echo here shows a type A aortic dissection, and you can see the intimal flap is in the aortic root, and this was also confirmed on CT. So aortic disease has been recognized as a significant cause of maternal death in pregnancy. Aortic dissection can occur at any point during pregnancy, but most commonly during the 3rd trimester or in the first few weeks postpartum. There are certain high-risk features that can be associated with poor outcomes, and this includes an aortic diameter of more than 40 millimeters, a family history of aortic dissection, or a family history of sudden cardiac death. And in these patients, you need to have a multidisciplinary approach to their care with a crisis plan in place to ensure prompt management of an aortic dissection should it happen. As per the European guidelines, pregnancy is contraindicated in patients with a bicuspid aortic valve if their ascending aorta measures more than 50 millimeters in diameter. In patients with Marfan syndrome, the cutoff is 45 millimeters and is 40 millimeters if the patient has a family history of dissection or sudden cardiac death. In Turner syndrome, because they have a short stature, we index the aortic size, and pregnancy is contraindicated if the aortic size index is greater than 25. In Louise Dietz, similar to Marfan syndrome, the cutoff is 45 millimeters and is 40 millimeters if the patient has a family history of dissection or sudden cardiac death. And finally, in Ehlers-Danlos, pregnancy is contraindicated in all of these patients. This here is from the ESC guidelines for the management of cardiovascular disease during pregnancy. And essentially, in patients with ascending aortic dilation, the recommendation is to repeat an echo every 4 to 12 weeks, depending on the diagnosis and the severity of dilation during pregnancy, and again, 6 months postpartum. Next, we're going to be talking about amniotic fluid embolism, which is a rare obstetrical emergency. It is characterized by acute cardiopulmonary distress and disseminated intravascular coagulopathy, which can happen during delivery or immediately in the postpartum period. Historically, it was thought that the amniotic fluid embolism causes a mechanical obstruction to the pulmonary artery. However, there is now emerging evidence suggesting that the amniotic fluid embolization to the pulmonary vasculature triggers an acute inflammatory response. And this in itself leads to severe pulmonary vasospasm and acute pulmonary hypertension. This here is a case that I was involved with last year where we had a 27-year-old pregnant patient with a clinical presentation in keeping with an amniotic fluid embolism. Her echo was in keeping with RV dysfunction. And we can see here the McConnell sign, which is characterized by RV mid-wall hypokinesis with apical sparing. The McConnell sign is associated with a high specificity for diagnosing acute pulmonary embolisms, but now there is an emerging evidence describing the McConnell sign in cases where you don't have thromboembolic involvement, such as the amniotic fluid embolism, which is mediated by pulmonary vasospasm and acute pulmonary hypertension. Next, we're going to touch on pre-eclampsia, and essentially it's a pregnancy-specific multi-organ syndrome that can affect 2% to 8% of pregnancies. It is mediated by vascular endothelial activation and vasospasm, resulting in hypertension and multi-organ hypoperfusion. The acute cardiac changes associated with severe preeclampsia have been investigated in the past. This here is a study that looked at the echo findings in patients with preeclampsia with severe features. And what they found was that the LV posterior and septal wall thickness were significantly greater in patients with preeclampsia compared to the control group. They also noted that 13% of patients with preeclampsia met the diagnostic criteria for grade 2 diastolic dysfunction. However, there were no differences in the systolic parameters between patients with preeclampsia and the control group. Additionally, there is now evidence that shows the association of hypertensive disorders of pregnancy and LV remodeling later in life. This here is a study that looked at the outcomes in women with a history of preeclampsia or gestational hypertension. And essentially, these patients underwent another echo 10 years after their pregnancy. And what they found was that women with both a history of preeclampsia or gestational hypertension, as well as a current diagnosis of hypertension, do have the most adverse echo findings. This included an increase to the septal wall thickness and a higher percentage of LV remodeling. These patients were also noted to have a significantly higher incidence of abnormal diastolic parameters. So this essentially suggests a double hit phenomenon. So women with a prior history of hypertensive disorders in their pregnancies, as well as a current diagnosis of hypertension, are a high risk group that warrants closer surveillance. Lastly, we're going to talk about peripartum cardiomyopathies. It is defined as the onset of systolic dysfunction and heart failure symptoms within the last month of pregnancy or during the first 5 months postpartum. The incidence of peripartum cardiomyopathy can vary by region. In the United States, the incidence ranges from 1 in 1,000 to 1 in 4,000. And outcomes can be variable. Some patients may have complete recovery. Some patients may deteriorate and require the need for mechanical circulatory support. An echo can help us predict the prognosis in patients with peripartum cardiomyopathy. This here is a study looking at the outcomes of patients with peripartum cardiomyopathies. And what they found was that most women recovered. However, 13% of patients had a major adverse cardiac event or persistent severe cardiomyopathy. More specifically, they found that women with an EF of 30% or more at the time of presentation had a higher likelihood of recovery. On the other hand, the percentage of women who died or underwent an LVAD implantation during the first year postpartum was significantly higher in patients with an initial EF of less than 30%. The authors also looked at the LV chamber size at the time of diagnosis and its prognostic significance. What they found was that a greater degree of LV dilation was associated with less chances of recovery. Patients with an LV end diastolic diameter of 6 centimeters or greater had lower EFs at 6 months and 12 months of follow-up. And when the authors combined both the LV end diastolic diameter and the ejection fraction, there was no evidence of LV recovery in all patients with both an EF of less than 30% and an end diastolic dimension of 6 centimeters or more. In addition to the LV size and the ejection fraction, there's also data to highlight the prognostic value of the RV function at the time of diagnosis in patients with peripartum cardiomyopathy. This here is a study that looked at the RV function in women with peripartum cardiomyopathy, and after adjustment for LV dilation and systolic dysfunction on multivariable analysis, the authors found that reduced RV fractional area change was an independent predictor of poor outcomes. And this included death, the lack of LV recovery, as well as the need for LVAD and cardiac transplantation. And that concludes my talk. Just to summarize, we talked about the hemodynamic changes in pregnancy and how they can be associated with normative structural adaptations. Such changes include chamber enlargement and annular dilatation. And it's important to note that these morphological and structural changes do normalize again in the postpartum period. In addition, diastology in pregnancy is an active area of research, and there's evidence to suggest the development of abnormal diastolic parameters in late pregnancy. In women with underlying cardiovascular disease, pregnancy can be a high-risk period, and as a result, a multidisciplinary approach is needed for the management of their care. We talked about the modified World Health Organization classification risk and its value in assessing mortality in pregnant patients with underlying cardiovascular disease. In certain conditions, such as severe mitral stenosis, pulmonary hypertension, and severe aortopathies, pregnancy is contraindicated due to significant morbidity and mortality risks. And we finally talked about the value of echo, not only in establishing diagnosis, but also to assess the long-term prognosis in patients with cardiovascular disease, such as pre-eclampsia and peripartum cardiomyopathy. These are my references. Thank you for listening. Do we have any questions?
Thank you, Rana, for creating or providing us such a comprehensive review of this particular topic. This is an issue or a clinical problem that we encounter not infrequently, especially in a very heavily immigration or immigrants heavy city that we have, because we do run into a lot of people with rheumatic heart disease, and in my practice, there's quite a few that we have to deal with to get them through pregnancy. And we're very fortunate at St. Michael's Hospital, where we actually have a very nice team to work together, including our group at internal medicine and also with our obstetrics group, so that we all work together on these cases and we get them through their pregnancy. And now I'm seeing a lot of them like in the teens, these young kids. So very gratifying. And obviously, these are very challenging situations when it comes to women with heart diseases during pregnancy sometimes. So, any questions from our participants? Thank you.
Chi-Ming, it's Bob Howard. Ran a great talk. Question about the peripartum cardiomyopathy.
Mm-hmm.
What are the thoughts about the mechanism for that? What causes it?
Great question.
And does usual heart failure drug therapy make a difference?
That's a great question. So, as of now, and as per Jack's statements on peripartum cardiomyopathies, it's unclear why certain patients or certain pregnant women develop peripartum cardiomyopathies, but there are certain risk factors. So women with a previous history of hypertension, pre-eclampsia, and they also noted that certain races can also be at higher risk for developing peripartum cardiomyopathies. And of course, genetics do play a role in this as well. In terms of GDMT and its role on helping reversal of the peripartum cardiomyopathy, I'm not entirely sure of any of the RCTs that were done in that specific patient population, but I'm under the impression that they would follow the classic CCS guidelines of heart failure for managing these patients.
Yeah, I can answer some of that actually, Dr. Howard, if you had a second. So Rana is absolutely correct. It's interesting that there is a strong genetic disposition, especially in patients who are of African descent, which suggests that there is something that is inherently genetic. And then as for the actual treatment itself, it actually is goal-directed medical therapy, but there are caveats to that. And the caveats are that you have to remember about lactation. So there are certain drugs that they have to reconsider in the context of a lactating mother for feeding the baby. But in general, the recommendations would be just to do GDMT and monitor as you would with anyone who has HFrEF or HFMAP.
Rana, it's Kim here. Great rounds. Yeah, just the other thing is there is, this concept about prolactin and how it may be involved in the development of peripartum cardiomyopathy. So there's some work looking at bromocriptine on that. This is obviously very small and it's not sort of standard of care. And just to remind folks that obviously if you, within the definition of peripartum cardiomyopathy, you can, have it within 1 month preceding delivery. So obviously we're a little bit cautious about RAS blockade there. So often the, goal-directed medical therapy is, it might be a little bit different there in that, hydralazine, isosulfide nitrate, digoxin, beta blockers, etc., are often used there. So as Chi-Ming mentioned, usually we reach out to our colleagues in this area and make certain that we're doing everything we can to protect the bub before it's actually born. So there are a few caveats there. Joel Ray's usually the guy at St. Mike's, but obviously in Toronto, the Sinai have a high-risk pregnancy group. And to be honest, a lot of these conditions, particularly folks that we're worried about, if they've got inherited aortopathy syndromes, Marfan's, Louis Dietz, we're usually pretty aggressive at getting them referred to that group. And also remind everyone that there is actually very, very rapid point of care testing now for genetics. So if you are concerned, if you ever encounter someone who you're worried that they could be, a Marfan's and there is a family history of sudden death or they've got Louis Dietz, we can usually get the genetic testing done and turned around for persons who are pregnant within 2 weeks. So it's not like the, routine genetic testing, which is often months. There is saliva-based kits, which we can fast track through the system. So if you're ever in that scenario, there's always someone you can reach out to who could really fast track things and get stuff done. So it's really evolving very rapidly, which is great because obviously if, we've had a couple of cases of folks that were worried actually did have Louis Dietz and, that really then brings up the question of pregnancy and pregnancy-related changes and whether or not you need to consider termination. So it is a very difficult area, and obviously the more opinions we get and being sure of the diagnosis beforehand can make the management, I think, well, it's not easy, but it can make it clearer what are the real risks and how we should approach it.
So indeed, I think, the highlight of this particular topic is the multi-team approach, and because now you have to involve both cardiology specialists and cardiology that are specialized in pregnancy, and structural heart team, heart failure team, and genetics, and aortic clinics. So it's really a multifaceted topic, and just a reminder to the trainees, this is a very common topic that appear in our national specialty exam, or in any country. So because it's an important topic, and Rana provided very, very good review of this topic, and just remember that you can review this video just before your exam and as part of your exam review.
Sorry to interrupt. There were a couple of things. One is in women with structural heart disease or a family history of congenital heart disease, we do fetal echoes here at St. Michael's Hospital, ideally at 18 to 20 weeks gestational age. So feel free to refer or recommend that they speak with their obstetrician for a referral. And then I guess the second discussion I wanted to have was with regards to the contraindication to pregnancy issue. I think it's a significant quality of life issue to tell a woman that pregnancy is contraindicated. So I wonder if that can be sort of separated into like an absolute contraindication versus we should make sure that we have adequate pre-pregnancy planning and intervention rather than as an absolute contraindication.
So that definitely, I think we are also very fortunate at St. Michael's in our group of cardiology colleagues. We have Dr. Hassan, who is a pediatric cardiologist. So we're very fortunate to have a relatively easy access to her expertise in this matter. And also she does fetal echo, and that also plays an important part for our patients who are pregnant, and then they can get the advanced testing done before delivery. So thank you, Rana. Any other questions or comments?
Jimmy, it's Kim here. Yeah, Rob, to that point, it is a very difficult issue to address. I've had a couple of persons who've had peripartum cardiomyopathy, and even despite our, best discussions and referring them to, the Sinai group and getting extra opinions, they've gone and got pregnant. And that obviously puts you in a difficult situation, because obviously we want to ensure that the mum survives the pregnancy. But as everyone's aware, once you've already survived the peripartum cardiomyopathy, getting pregnant second time, the risk profile is even much greater. So it is, it is a difficult area. I think that's partly why we've tried to sort of spread the opinions around and educate people as best we can. But at the end of the day, we've had the same scenario with folks who have got Marfan's and had aortas of say 42 and 43, and then the question is, what do you do? And it's always a very difficult decision, because obviously once that person is pregnant, then the discussion, well, do we need to terminate, and all the issues around that. So it's a really important question. I think we've just got to educate as best we can, and ultimately understand that some people might make a decision, that's their prerogative, I guess. But at least if we've had that upfront discussion, so people are much clearer of the risks, that can help. As I said, it's never an easy decision, but maybe a better way forward to try and guide and provide guidance. These are always very difficult, and we've had a few people with severe MS. We've usually got Bob Chisholm involved here as well, just to get his opinion. And often, Bob, having so much experience with valvular heart disease, has been very successful in helping folks get through that with a balloon valvuloplasty during the pregnancy, followed by, appropriate follow up with the obstetric high risk obstetric team. But yeah, it's always a difficult thing because, as you said, we don't want to sort of bandy around pregnancies contraindicated because of the issues, and there's actually fairly it's actually a fairly select group of conditions where it truly is, I think, contraindicated because of both the infant and the mother mortality rates are so high. But I think, Rana, you did a good job in trying to show where those are, and that hopefully with pre-pregnancy counselling that we can identify those and give people the right opinions or address what we can pre-pregnancy so that they can then go ahead and successfully get pregnant and have a successful delivery.
Great. This topic also reminds me of how we organize ourselves from a system point of view. As we move along in our healthcare development, it seems that we're getting more and more specialized in each of our hospitals, where we only specialize in a number of areas. But St. Michael's remain one of the urban angel in downtown Toronto, where we are truly general hospital, where we actually have most of our care within one roof, so as to say, because we actually deal with patients with obviously heart disease, but also we have a very strong team of obstetrics and gynecology, where children are actually delivered, etc., etc. So it's really wonderful to be able to have such a team of colleagues within one roof to be able to care for patients in this situation. Any other comments or discussions? Great participation. Thank you.
Maybe, Chiming, a quick question. Is there any experience with women with hypertrophic cardiomyopathy and pregnancy? What happens with them?
I think HOCM, HCM in general, is well tolerated in pregnancy. I'm not sure if there is a certain cutoff in terms of which patients are safe to go ahead with pregnancy or not. But in general, it was not under the higher risk category group.
Yeah, Bob, it's Tom. I think there was always a general belief that the volume loading actually reduced outflow tract gradients in pregnancy.